Great.
Yes,
So
sir.
we'll start. I'll share my screen.
Sure, sir. Sure.
So it is visible now?
So it's about, yes, sir. Now it's there, sir.
It's moving?
Yes, sir.
Okay. So shall we start or we
Yes, sir.
should
Please, sir.
wait
Thank
for?
you. It's all yours, sir.
Okay. So we'll start then. Okay, great.
Sure, sir. Please. Thank you.
Uh, so today we are going to discuss about BAM scoring a kidney transplant, and it will be very, I'll start from the beginning, how the BAM scoring, how we used to label anything as a rejection, tubular interstitial or vascular. So for that, we need to start from the beginning. So that means 1991, the first BAM meeting was conducted. So we'll start from there and then we'll go up till 2023. So as we know, the BAMF classification, if you go through this photograph, it shows that uh, we do all these investigations. There is a specific role of all these investigations, whatever we do. And the role of BAMF classification, I'll use a pointer. Okay. And the role of BAMF classification is mostly in these areas. When you see, you have to assess the disease diagnosis and to assess the disease stage or severity. So before this, before the biopsy diagnosis, there are two things we do. We do risk analysis just to assess that what is the future disease risk. Just to avoid, just to assess that future disease risk, we do these risk markers, which is like HLA, PRA, HLA, DSA, non-HLA antibodies, all these things. And to assess the ongoing disease activity, we do non-invasive diagnostics like serum creatinine, eGFR, proteinuria, the blood markers we do, DNA markers, polyoma virus, PCRs, and all that stuff. Uh, now, the BAF classification is done on an invasive procedure, and this invasive procedure is kidney biopsy. So on kidney biopsy, we do a histological BAF classification. And in addition to that, now most likely in near future, we will be including the molecular diagnostic part also in the classification system. So at present, there are some molecular transcripts which suggest that if this molecular transcript is there, it suggests a T cell mediated rejection. If this molecular transcript is there, it suggests an antibody mediated process. But still, a lot of studies has to be done on these molecular diagnostic parameters. And at present, the classification system, it says that molecular proven markers should be there, but it is not like it should be there. It is like if they are available, you can utilize them. But this thing is sure that at present we don't have any specific molecular transcriptomes which suggest that this is surely AMR and you don't have to do anything else. So the role of renal biopsy remains good, and renal biopsy will help in further assessing the disease activity also as well as the disease chronicity. Because what you can see here is just to assess the disease stage as well as severity. When we say this is active disease, that means if you find thrombotic microangiopathy, if you find glomerulitis, if you find PTC capillaritis, all this suggests a active disease. On the other hand, if you see a lot of chronicity in form of tubular fibrosis, tubular atrophy, interstitial fibrosis, or a chronic vascular rejection like transplant arteriopathy, all these findings suggest that this is a more like a chronic disease. So kidney biopsy helps in first diagnosing what type of rejection it is, whether it is a T cell mediated rejection or an antibody mediated rejection. And the second utility of doing the kidney biopsy is that it will assess the activity as well as the chronicity of rejection. Okay. And these are the other parameters. This is after the kidney biopsy, the prognostication, prediction of therapy response. So all these things, they have got a specific role. And BAMF classification deals only with the kidney biopsy diagnosis as well as for assessing the disease stage as well as severity. So since its introduction, the BAMF classification. Since its first consensus meeting in 1991, the BAMF classification of allograft pathology has provided a framework for reporting of renal allograft biopsy, and it was the first classification system which answered the need for an international consensus on renal transplant biopsy reporting. It provided guidance for clinical diagnosis, and, and it also helped in enabling meaningful comparison between research studies and clinical trials investigating the diagnosis, treatment, and outcome in kidney transplantation. And the first BANF meeting was done in 1991, and the article was published in 1993, Kidney International. And I'll highlight the BANF categories. The BANF 1991 categories, these were the broad 6 categories which were provided in the BANF 1991 scoring system or classification system. The first was, if you find a normal biopsy, that means there is no evidence of any interstitial infiltrate, and there is no evidence to suggest any antibody-mediated process. Then there is a hyperacute rejection. Nowadays, you hardly come across this terminology of hyperacute rejection, except in ABO incompatible transplant. See, what happens is hyperacute rejection used to be, we as a renal pathologist, we follow Heptinstall textbook of renal pathology. And if you look at the older editions, you will find a chapter on hyperacute rejection. But with a good immunopathological workup, now we hardly come across hyperacute rejections, except in a setting of ABO incompatible transplant, where despite doing DSAs, despite doing anti-blood group antibodies, still patients, some of the patients, they land up in hyperacute rejection. Then there are borderline changes of rejection, the third category. The fourth category was acute rejection. And if you look carefully, the acute rejection was graded as grade 1, grade 2, as well as grade 3. And there was no further subtyping of acute rejection, whether it is a acute cell-mediated rejection or whether it is in cell-mediated also, whether it is a tubular interstitial type of rejection or vascular rejection. Okay. And there was no mention of, as such, the antibody-mediated rejection was like mentioned only as a hyperacute rejection. So acute rejection, there was no categorization of acute rejection into tubular interstitial or vascular rejection. Okay, it was only labeled as grade 1, grade 2, grade 3. Grade 1 means mild acute rejection, grade 2 means moderate acute rejection, and grade 3 means severe acute rejection. Then the fifth category was chronic allograft nephropathy. So any kind of tubular trophy or interstitial fibrosis that was clubbed into chronic allograft nephropathy. And this terminology nowadays we don't use. So in 1991, this chronic allograft nephropathy terminology was included in the 1991 BAF categories. And the sixth category was like other changes not considered due to rejection, which included infections and all that stuff, other things. Now in BAF 1997, if you see the categories, there was certain changes. Like for example, the hyperacute rejection, that was termed as an antibody-mediated rejection, and it was divided into immediate, which was called as hyperacute, or delayed, which was called as an accelerated acute antibody-mediated rejection. The borderline thing was remained the same. Now, if you look at the acute rejection or active rejection, this was divided into 1A, 1B. Now they have categorized it into, they have subclassified this acute rejection into 1A, 1B, 2A, 2B, and type 3 rejection, type 3 acute rejection. So 1A means if you find an interstitial inflammation which is significant. So the interstitial inflammation has to be more than 25% to be labeled as acute cellular rejection. If the interstitial inflammation is less than 10%, that means it is I0. Okay. If the interstitial inflammation is 10% to 25%, it is I1. And if it is more than 25%, it is I2. And more than 25 to 50% is 25 to 50% is I2, and more than 50% is I3. And the tubulitis, if it is mild, that is T1, that means 0 to 4 or 1 to 4 lymphocytes in the one tubular cross section, 5 to 10 lymphocytes, that is moderate tubulitis, and severe tubulitis is more than 10 lymphocytes, or if there is a tubular destruction. So similarly, the 1A rejection, cases with significant interstitial inflammation, that means more than 25% of the parenchyma affected, And there are foci of moderate tubulitis. That means more than 4 mononuclear cells per tubular cross section in a tubule which consists of group of 10 tubular cells. Case 1, type 1B was if you find severe tubulitis. So if you find severe tubulitis, you have to label it as a 1B type of rejection. The type 2 rejection was further subclassified into 2A and 2B, and 2 and 3 means that there is a vascular rejection. 2A, 2B means there is a mild vascular as well as a severe vascular rejection, but 3 means there is a fibrinoid necrosis of the vessel wall or a vasculitis-like rejection. So what you have to remember is tubular interstitial rejection is 1A, 1B, which includes interstitial inflammation as well as tubulitis. Type 2 rejection includes the vascular rejection. So that means if there is a mild to moderate intimal arteritis, that was labeled as V1 lesion. Okay. And if there was a severe intimal arteritis comprising of more than 25% of the luminal area, it was labeled as V2 lesion. And both these are vascular rejections. And then there was a very severe vascular rejection, I would say, because here also it is like written as severe intimal arteritis. So this is a very severe vascular rejection in which there will be either fibrinoid necrosis of the vessel wall, or the inflammation will go through the entire wall of the vessel. That means from intima, media to adventitia. So all the 3 layers will be affected. That is called as a transmural. So it is going through the media. So it is a transmural kind of inflammation. So either a transmural arteritis or there is a arterial fibrinoid change or necrosis of the medial smooth muscle cells. So these lesions are labeled as V3 lesion, and it was thought that V3 lesions are accompanied by lymphocytic inflammation. And it was believed that V3 lesion, whenever there is a very severe vascular rejection, fibrinoid necrosis and all that, it is mostly associated with antibody-mediated rejection. So V3 lesion were considered as, if V3 lesion is there, think more of antibody-mediated rejection. So I'll show you some images of tubular interstitial rejection. If you look at this biopsy, you can see that there is a lot of interstitial inflammation. You can see all these blue cells. And there is some subjectivity among pathologists also. So some may say the inflammation is like more than 50%. Some may say that it is like, I would say 40 to 50% rather than more than 50%. But surely everyone will say that there is interstitial inflammation. So based on that, you can see a I score of 1, 2, 3. Okay. So you can see there. So in a tubular interstitial rejection, you are going to see the interstitial component, which is highlighted here as blue cells which are lying in the interstitium. That means there is interstitial inflammation. And another view of this interstitial infiltrate, which can be seen here, is you can see these blue looking cells, the lymphoid aggregates which are there. Okay. And these lymphoid aggregates suggest that there is good amount of interstitial infiltrate. Now, when we scored tubulitis, we scored T1 to T3. Now you can see this tubule, okay, and in this tubule you can see this 1 lymphocyte, 2 lymphocyte, 3, 4, all these small cells, possibly 5, okay. So, and these lymphocytes are infiltrating into this tubule, and these larger cells, these are tubular epithelial cell nuclei. So that means they are infiltrating into the tubule. So I'll highlight this tubule also. Okay, in this tubule you can see, and whenever a lymphocyte infiltrates into the tubular cytoplasm, there will be a perinuclear clearing, which will be there, as you can see here. Not in all the cases, but majority of the times you will see a perinuclear clearing. You see a nucleus here, and surrounding that nucleus, there is a clear space. So if you count these nuclei, 1 lymphocyte here, 2nd lymphocyte, 3rd, 4th, 5th, possibly 6th, and 7th. And all these larger cells, these larger cells, this larger cell, this larger cell, these are tubular epithelial cells. So there is evidence of tubulitis along with interstitial inflammation. So this is a tubular interstitial type of rejection. There was no vascular involvement. So it is either we label it as a type 1A or type 1B. Okay, depending upon if I find severe tubulitis, I label it as type 1B. And if the tubulitis is moderate, mild, moderate, I label it as a type 1A tubular interstitial rejection. Now we come to the vascular rejection. In the vascular rejection, what you can see here is you can see this. This is the normal lining. You can see the flattened or elongated nuclei. This is endothelial cell. You can see this endothelial cell nuclei, and there is a lymphocyte beneath this endothelial cell. So now, now you see this elongated cell is endothelial cell, and beneath that there is 1, 2, 3. There are 3 lymphocytes. Similarly, if you follow this endothelial lining, you can see endothelial lining here. You can see endothelial line cell here. But beneath that, there is a lymphocyte, which is causing lifting of the endothelium. Okay. And if you see a lymphocyte just beneath the endothelial cell, which is causing lifting of the endothelium, it is consistent with intimal arteritis or endothelitis. Here also, all these are lymphocytes which are there in the intima. Okay. Now, if the lymphocytic infiltrate or endothelitis involves less than 25%. So here you can see this is the endothelial cell, this is the endothelial cell, and beneath that there is lymphocyte, beneath that there is a lymphocyte. And you can compare this with this area. So here the endothelial cell is there, but there is no lymphocyte beneath this endothelium. So endothelitis is there, but it is involving less than 25% of the luminal circumference of the entire vessel. So if this is the entire luminal circumference, it is involving only this area. Okay, so that means less than 25%. On the other hand, in this vessel, you can see that this is the complete luminal circumference from this area till this area, and you can see the endothelitis, which is involving this from here to here. So that means it is more than 25% of the luminal area is involved by the endothelitis process. So that means it is, if the more than 25% luminal areas is involved, it is called as a 2B kind of vascular rejection or V2 lesion. And if it is less than 25%, it is called as a V1 lesion. Now, on the other hand, if there is a V3 lesion, that means the inflammation is seen. You can see this inflammatory cells which are going throughout the wall of the vessel, or there is necrosis of the wall. You can see here, there is necrosis of the vessel wall. So if you find inflammation which is transmural throughout the wall of the vessel, or if you find necrosis of the vessel wall, it is a V3 lesion. Now, the antibody-mediated rejection criteria, it was laid down, it was only in 1997, the BAMF 1997 classification, that they highlighted that there are some specific features of antibody-mediated rejection. And what were those specific features? They suggested that if there is ATN, so morphology of AMR was elaborated in this classification system. So they said that if there is, so this was a BAMF 2003 category, and it showed that if there is a ATN with C4D positivity or minimal inflammation, if there is capillary margination or thrombosis. So when I say margination or thrombosis, that means either there is TMA when I say thrombosis, or margination means there is glomerulitis and there is peritubular capillaritis. Okay. And what I want to highlight here is V3. So it was believed in 2003 also that if there is a severe vascular rejection or V3 lesion, then only it is acute antibody-mediated rejection. V1, V2 lesions, they were not considered as antibody-mediated process. They were considered as, they are possibly related to acute T-cell mediated rejection rather than an antibody-mediated rejection. So if you look at the categories, previously also there were 6 categories. The normal category is still persisting in 2003 also. There is a antibody-mediated rejection, and instead of accelerated and delayed kind of rejection, that criteria was removed, and they have said that grading will be 1, 2, and 3 based on if there is ATN like picture, if there is a capillary margination, or there is a V3 type of lesion. Then there was a borderline changes which was suspicious, which category was maintained. Acute or active T-cell mediated rejection, which I have discussed in 1997 BAMF categories, 1A, 1B, 2A, 2B, and 3. And the terminology of chronic allograft nephropathy was still persisting in BAMF 2003 classification system. Now, I'll show you some images of acute antibody-mediated rejection. So when we label anything as acute antibody-mediated rejection, there has to be some histological criteria. And these histological criteria are if you find acute tubular injury. So when I say ATN, so ATN means that majority of the times the tubules are arranged in a back-to-back manner. Okay. But if you find tubules which just show slight separation from each other, or the tubular lumina is big and there is flattening of the tubular nuclei that suggests acute tubular injury. Some people label it as acute tubular necrosis, ATN, but a good number of pathologists believe that terminology of necrosis is not correct. It should be labeled as acute tubular injury rather than acute tubular necrosis. Okay, because they say that majority of the times you don't find necrosis of the tubular epithelial cell. It is just that there is flattening, there is dilatation of the tubular lumen, but there is no necrosis. Now, this is a high magnification. Just see, you can see these tubular nuclei, 1 nucleus, 2 nucleus, 3 nucleus, 4, 5. And in this area, you don't find any nucleus. And then again, one more nucleus will come. And then there is no nucleus till this area. Okay. And what you can see inside the tubular lumen is all this cytoplasmic fragments. Okay, these are all cytoplasmic fragments of the tubular cytoplasm. So all these findings suggest that there is some form of tubular injury which is going on. This is a distal tubule where you can see all the nuclei are well arranged, they are uniformly placed, and just compare this tubule with this tubule, and you can see that there is loss of tubular nuclei at places, and there is dilatation of the tubular lumen, and there is shedding of the cytoplasmic fragments into the cytoplasm or into the shedding of the tubular cytoplasmic fragments into the tubular lumen. The other criteria is there has to be capillary thrombosis or thrombotic microangiopathy. So you can see these are the glomerular capillary loops which are full of these fibrin thrombi which are there. They are also showing this stuff which is all these are RBCs. So there is capillary congestion and there is presence of this pink color stuff which is thrombi, which is fibrin actually. And this is a pH stain which further highlights. So some of the capillary loops are showing this fibrin within the capillary lumen, but some of the capillary lumen, glomerular capillary loops, they are showing a lot of inflammatory cells. They are neutrophils and occasional lymphocyte. So this is called as microvascular inflammation or glomerulitis. So if you find a lot of inflammatory cells within the glomerular capillary loops. And now the inflammatory cells can be seen in the mostly in the microvascular inflammation means the inflammation has to be in the smaller tiny capillaries. And these tiny capillaries are the glomerular capillaries as well as in the peritubular capillary. You can see this peritubular capillary, and this peritubular capillary is showing lot of neutrophils. You can see these neutrophils. So there are a lot of neutrophils which are seen in this peritubular capillary. There has to be V3 lesion, so fibrinoid necrosis. So just compare this area of the vessel wall with this area, and this area is completely necrosed. Okay, so if there is a complete necrosis of the vessel wall or vasculitis kind of vascular rejection, then you should think of acute antibody mediated process. And C4D has to be positive. So C4D can be done by immunofluorescence as well as by immunohistochemistry. Any methodology is good enough. If you get a separate core in normal saline, you can do C4D immunofluorescence. But if you are having only one core in formalin, then you have to do C4D immunohistochemistry. So you can see that the staining is in the peritubular capillaries. So all these are peritubular capillaries which are showing staining. And if the C4D is negative in the peritubular capillaries and morphologically you find duplication of the glomerular capillary wall, there is a suspicion of chronic antibody mediated process, we should also look C4D staining in the glomerular capillaries. Though the glomerular capillary staining, the BAMF has not highlighted that glomerular capillary wall staining is consistent with the chronic antibody mediated process. But what we have seen is if immunofluorescence, the other immunoglobulins are negative, and you find glomerular capillary wall staining, and there is a morphology which suggests that there is a transplant glomulopathy, there is a microvascular inflammation, that even the glomerular capillary wall staining, if it is strong enough, then it is pretty consistent with a chronic antibody mediated rejection. So in 2005 BAMF category, there was an elimination of the non-specific term which is called as chronic allograft nephropathy. And there was a recognition of entity labeled as chronic antibody mediated rejection. So the terminology of CAN was replaced by chronic allograft. So it was divided. It was actually the CAN was replaced, I would say, by two things. One was a chronic antibody mediated rejection. So chronic antibody mediated rejection means that the process is because of the antibodies which are persisting And in that you see a diagnostic triad, which I'll highlight it further. And the terminology of CAN was eliminated and it was replaced by IFTA, interstitial fibrosis and tubular atrophy. So CAN was replaced by IFTA, and the new entity was recognized, which was called as chronic AMR. So in 2005, these two changes, major changes occurred. So in 2005, so this terminology of chronic active antibody mediated rejection came in, and there were diagnostic criteria, histological criteria which were laid on, which included glomerular double contours on light microscopy, peritubular capillary basement membrane multilayering. This you see PTC multilayering only on electron microscopy, and or there has to be tubular atrophy or interstitial fibrosis, or if you can find some thickening in the arteries along with C40 posture. So practically, you have to look for chronicity in all the compartments. So in a kidney biopsy, we look at three compartments. One is a globular compartment, the second one is a tubular interstitial compartment, and the third is a vascular compartment. So if you find chronicity in the globular compartment in form of duplication of the globular capillary loop, you label that as transferring glomulopathy, okay, or a chronic glomulopathy. If you find tubular atrophy, interstitial fibrosis, that is a chronic type of thing which happens in the tubular interstitial compartment. And if you find a vascular rejection, which is chronic, that means you find intimal fibrosis or fibrous intimal thickening in the vascular compartment. That also suggests it is chronic. The opposite to that is if you find more fibrin thrombi, if you find or a glomerular TMA or fibrin thrombi, if you find mesangiolisis, if you find lot of neutrophilic glomerulitis, all these findings suggest it is acute process in the glomerular compartment. If you find tubulitis and interstitial inflammation, it is more consistent with the acute process of acute tubular interstitial changes. And if you find endothelitis or active endothelitis and no fibrous intimal thickening, it suggests it is an active endothelitis. So opposite to that is all chronic. Okay. So for example, the terminology of CAN, that was replaced by IFTA. So this is a Mason's trichome stain. This is a Mason's trichome stain, and it shows that there is greenish color. Sometimes you'll find a blue color also. It all depends on the counter stain what we use. So if you use a blue counter stain, it will be blue in color. But if you use a green counter stain, it will be green in color. The interstitial fibrosis will be green. So Mason's trichome stain highlights this greenish kind color in the interstitium. So that means there is a lot of interstitial fibrosis, and this is a PS stain on this side. So this is a PS stain section, and you see these patches of tubular atrophy. You can see these smaller tubules with narrowed lumina, and just compare these tubular lumina. Just compare this tubular lumina with this tubule with a good luminal circumference. You can see this. You can compare these normal-looking tubules with these atrophic tubules. So presence of tubular atrophy and presence of interstitial fibrosis. So IFTA terminology was a new terminology, and it replaced the older terminology, which was chronic allograft nephropathy. So in 2007 classification system, there were further updates on antibody-mediated process and antibody-mediated rejection. And the C4D was, the scoring of C4D was done in 2007, in which they scored C4D as C4D negative, and the staining was was not there in peritubular capillaries. It was labeled as C41. There was, if there is minimal staining, 1 to 10, less than 10%. C42 if it was 10 to 50%, and C43 or diffuse staining when it is more than 50%. And it was suggested that if you do C4D by immunofluorescence, then C4D 0 and 1 should be considered as negative, as you can see here. And if there is a focal staining, the significance of focal staining was unknown. And if more than 50% of PTC shows staining, it was considered as positive. On the other hand, IHC, if there is 0% staining, that is negative. But if it is less than 10% staining, the interpretation of this result was unknown. And if it is more than 10 to 50% staining, they said query positive. But one thing was sure, it has to be more than 50% to be labeled as positive by either immunofluorescence or immunohistochemistry. The good thing about C4D immunofluorescence is the normal mesangium act as a control. You can see these two glomuli here, okay? And these two glomuli show that this area is the mesangial area, the greenish looking area, okay? So it is all mesangial area. But when you interpret C4D, you interpret in the peritubular capillary. So all these are, this area is complete black. So that means there is no staining of the peritubular capillaries. So in comparison to that, just look at this image, which shows significant peritubular capillary staining. So this is C4D positive, and the previous image which I showed you, this is C4D negative. And in immunofluorescence, the normal mesangial staining, it acts as a control. So you know your C4D is 1. But in immunohistochemistry, there is no positive control as such. The normal mesangium will also be negative. And sometimes the C4D staining is very minimal. You can see here, it is only less than 10% of PTCs, which is showing the staining. And according to the BAM classifications, BAM scoring of C4D, the C4D score 1, which is less than 10% of PTC, was considered as negative. So if we look at the triad of late chronic allograft mediated rejection, so there are morphological criteria, and these morphological criteria are transplant glomulopathy, where there is duplication or double contours in the globular basement membrane, and it was labeled as CG score, CG1, 2, 3. If there is peritubular capillary basement membrane multilayering, this PTC multilayering, this is based on electron microscope. Okay, so if you say PTC multilayering, that terminology is used only on electron microscopy. If there has to be IFTA with or without PTC loss, and fibrous intimal thickening in the artery. So practically all the compartments, the globular compartment show transplant glomulopathy. The tubular interstitial compartment show IFTA, okay, and the vascular compartment will show fibrous intimal thickening. And you can also include the vascular compartment, the peritubular capillary basement membrane multilayering also in the vascular compartment. In addition to all this, there has to be diffuse C4D deposition in the peritubular capillaries. And the third thing is there has to be presence of donor specific antibodies. So this is the image which highlight this further, that you can see the duplication of the glomerular capillary loops, okay, which I'll highlight in 1 or 2 more images. There is IFTA, there is intimal, this is a vessel which is showing thickening of the intima. So there is intimal thickening, and this is electron microscopy which shows peritubular capillary basement membrane multilayering, and C4D has to be positive. So this is the high magnification to highlight. You can see, just compare this area of the glomerular capillary loop with this area, and you can see a duplication. You can see one membrane like this and one membrane like this. So there are 2 membranes. So it suggests there is a duplicated capillary loop. Similarly, you can see here, there is one membrane like this and there is one membrane like this. So there is a duplication. Okay, so presence of duplication of the glomerular capillary wall, whenever it is there, it is synonymous with transplant glomulopathy. Similarly, another image highlights that you can see this area which is showing a clear space in the glomerular capillary wall. So this is also a duplicated glomerular capillary wall. Similarly, you can see one capillary wall here and one capillary wall here. So there is a duplicated space, and you find these cells within the glomerular capillary loops. This is called as glomerulitis. You can see this glomerulitis here. So, so one thing I want to highlight, when we say transplant glomulopathy, it just means that there is a non-uniform thickening and there is a duplication of the glomerular capillary wall. And transplant glomulopathy is not synonymous with chronic antibody-mediated rejection. Transplant glomulopathy has got, if you find transplant glomulopathy, that means you consider 3 differentials. First is chronic antibody-mediated rejection. Second is chronic thrombotic microangiopathy. And the third differential is MPGN, which could be recurrent or de novo MPGN. Okay. If immunofluorescence studies are negative, that rules out possibility of MPGN. Okay. So in this case, the image I'm showing you, there is duplication. There are some cells within the glomerular capillary loop. So morphologically, you may say that there is endocapillary hypercellularity, there is duplication. It could be MPGN, but immunofluorescence is negative in this. So this rules out possibility of MPGN. So you are left with only 2 possibilities. Either it is a chronic antibody-mediated rejection, which is producing this duplication. And the second is if it is a chronic thrombotic microangiopathy. In a chronic thrombotic microangiopathy, I don't expect these inflammatory cells within the glomerular capillary loop. So if you find glomerulitis in the glomerular capillary loops, along with that, you find PTC capillaritis, and if C4D positivity is also there, all these findings are more in favor of a chronic antibody-mediated rejection. So what I want to highlight is transplant glomulopathy term is not synonymous with chronic antibody-mediated rejection. Transplant glomulopathy just means that there is a duplication of the glomerular capillary. So this is a silver stain which further highlights these duplication, and you can see that sometimes the duplication is significant. You can find one capillary wall here and one capillary wall here. So this complete area is markedly expanded. There is duplication. Similarly, this area also, you can see a duplication of the glomerular capillary wall, which is seen. Now, so when you see this kind of a duplication of the glomerular capillary wall, and if you do electron microscopy in the same case, you are going to see multi-layering. So this is a glomerular basement membrane, and just compare this GPM with this area of the GPM, this area. So this area of the GPM, you find one layer, you find two layer, and you find a third layer. So this is called as GPM multi-layering. Okay. So GPM multi-lamellation or multi-layering is more consistent with the chronic antibody-mediated process. If you look at PTCs, just see this PTC, which is showing one lymphocyte here. This PTC is showing two lymphocytes here. This PTC is showing three lymphocytes here. And if you look at the thickness of the PTC at places is more than the thickness of the tubular basement membrane. That suggests whenever there is a repeated endothelial injury, there has to be thickening of the glomerular capillary wall or peritubular capillary basement membrane layer. So if you find thick wall PTCs with PTC capillaritis, it is also one of the diagnostic feature of chronic antibody-mediated process. This is a peritubular capillary under ultrastructure examination in EM. So it will show, you can see these layers, you can see multiple layers here. So all these multiple layers, one like this, 2, 3, 4, 5, 6, 7 around. So if you find 5 to 7 layers in 3 peritubular capillaries, multi-layering is there. That is also consistent with chronic antibody-mediated process. In the Mason's trichome, if you find intimal fibrosis, so you can see this intima, which is like this. This is a mild intimal fibrosis, and both these are Mason's trichome stain, and this shows that there is a significant intimal thickening. Normally, intima sits directly on the media. So in this case, what is happening? This green color intima is markedly thickened, and this thickness is double than the thickness of the tunica media. So all these findings suggest that there is moderate intimal sclerosis or intimal fibrosis. So there were BAMF working groups also, which were formed in BAMF 2009 classification system or BAMF 2009 meeting. And they formulated some groups. One of the group was isolated V lesion working group. So isolated V lesion working group means, I'll show you one case. So this was a patient, first transplant was done in 2005, donor was wife, CMV was there in 2005, CMV was CMV PCR was positive in blood. There was a second transplant which was done, and donor was brother-in-law, and HLA match was 4/6. 4/6 mismatch was there. Basic disease was unknown, and graft biopsy was done on POD6 with rising serum creatinine. So what you find in this biopsy is there is some acute tubular injury. Why I am saying tubular injury? Because the tubules are separated from each other. There is some space which is there in between tubules. So that means there is interstitial edema. You can see this glomerulus, which I'll show you in the high magnification also. Since there is no pathology, I'll be showing dominantly this vessel, because the dominant pathology was there in this vessel, and there is no evidence, no significant amount of interstitial inflammation which was seen even at this magnification. So if you look here, so there is a very minimal kind of blue cells which are there in the interstitium, but this area I want to highlight. So the main pathology was there only in one vessel, and this vessel showed evidence of endothelitis. You can see this flat endothelium, which is normal, which is sitting on the media. And this area, just compare this area with this area, and you can see that there is a endothelial cell which is lifted, and there is a lymphocyte beneath it. So that means there was some minimal intimal arthritis. Another view highlights that there is a Just compare this area where the flat endothelium is there, but there is no lymphocyte beneath this. On the other hand, this area, it shows that there is a endothelial cell and there is a lymphocyte beneath this. So that means there is intimal arteritis. There was no, there was some amount of, I would say that PTC capillaritis also, you can see this PTC with some amount of capillaritis. You can see some minimal kind of glomerulitis also. But remember, whenever there is a vascular rejection, you will find minimal amount of glomerulitis. So since there was no tubulointerstitial inflammations, there was no interstitial inflammation, there was no tubulitis, and it was only one vessel with evidence of intimal arteritis. This is labeled as an isolated P lesion, or in other words, you can also call it a BAF type 2A vascular rejection. This patient improved with 5 doses of methylprednisolone. I'll show you another case. 28-year male renal transplant. Transplant was done in 2014. Donor mother, graft dysfunction, rising serum creatinine. 2 biopsies was done, POD7 and POD30. So in the POD7, there is no interstitial inflammation, but this vessel is showing something which I'll show in the high magnification. So you can see that there is some interstitial inflammation which is there, and this vessel is showing interstitial infiltrate here. So it is involving more than 25% of the luminal circumference. So it is like a moderate kind of intimal arteritis or a V2 lesion. There was some smaller vessel also, which was showing this lymphocyte in the endothelium. So there were 2 vessels, similarly one more vessel with evidence of endothelitis. So this was a type 2B kind of vascular rejection, and there was a type 2A, which I've already mentioned before. There was no, the PTCs were congested, but there was no PTC capillaritis as such. The glomeruli also were not showing any glomerulitis. The glomerular capillary loops were empty. They were not showing any cells. C4D was negative. There was no staining in the peritubular capillaries. The staining was only in the mesangium. And this was labeled as acute cellular rejection, BAMF type 2B. Or this can also be labeled as isolated B lesion because there was interstitial inflammation which was just 10 to 10%, 10 to 15%, not significant. And there was no tubulitis as such. The dominant pathology was in form of a vascular rejection. Now, this patient also managed with 5 pulse methylprednisolone. Initially, there was mild reduction in serum creatinine. However, after 2 days, there was rising trend. DSA-Lizate was done during that time. This is a 2014 biopsies, and now we hardly go for DSA-Lizate. It is not a very good method to do donor specific to demonstrate donor specific antibodies. A repeat biopsy was done on POD13, and repeat biopsy shows, as compared to the previous biopsy, this biopsy shows complete fibrillar necrosis of the vessel wall. Okay, so that means the rejection, which was 2B, it has transformed to a higher grade vascular rejection, that is a type 3 vascular rejection. This, in other words, this is a V3 lesion. This is a V3 lesion. Okay. This is just to highlight that you can see type 2B rejection in the first biopsy, and the second biopsy show a type 3 vascular rejection. First biopsy rejection, which is like mild, and the second biopsy show a transmural inflammation. You just see the lumen, which is seen in the first biopsy, and you hardly see any lumen. This is just a slit-like lumen, which you can see in the second biopsy. So that means the vascular rejection was more severe in the second biopsy. And the clinical behavior also suggests that this patient is not improving with 5 pulse methylprednisolone. And as compared to the first biopsy, which was showing no PTC capillaritis, only PTC congestion, RBC is being there. The second biopsy show presence of PTC capillaritis. As compared to the first biopsy, where there was no glomerulitis, no cells within the glomerular capillary loop, the second biopsy showed more cells within the glomerular capillary loop. So that means as compared to the first biopsy, the second biopsy show more PTC capillaritis. Not more, the second biopsy show PTC capillaritis as well as glomerulitis. C40 in the first biopsy was negative, and C40 in the second biopsy also was practically negative. It was less than 10% PTC, which was showing some staining. So by BAF criteria, it is considered as negative. But morphology is highly suggestive of acute antibody-mediated reaction. Why? Because there was V3 lesion, plus there was microvascular inflammation. The microvascular inflammation was there in form of PTC capillaritis and glomerulitis. Okay. Yes, the one thing was absent, the TMA was not there. Okay. And the other thing which was absent was the C4D also was negative. So it was suggested that isolated V lesion working group was formed, and it is suggested if C4D is negative, then you treat this as T cell mediated rejection. But it was said that 18% of these isolated V lesions can show uh, DSA, which is positive. And in patient with isolated V lesion plus DSA and microvascular inflammation, adding anti-B cell or antibody depleting strategies to steroids may possibly prolong the graft survival. But there are papers, recent papers on isolated V lesions, which say that there are some papers which suggest that early isolated V lesion. It is suggested that if you see isolated V lesion the first 1 year post-transplant, consider that as just a ischemia reperfusion injury rather than a T cell mediated rejection. But if you find isolated V lesion more than 1 year post-transplant, consider that as a manifestation of antibody-mediated process. So biopsies with isolated V lesion should be assigned a differential diagnosis based on the TSA, based on the time of transplant, and based on presence or absence of mild duplantition lesions. Less than 1 year, so first few months, if TSA is negative, if there is no I0 means no interstitial inflammation, T0 means no tubulitis, usually it is no rejection and it means just a ischemia reperfusion injury. On the other hand, if you find more than 1 year post-transplant, you find DSA which is positive in mostly all majority of the cases, and post 1 year post-transplant, isolated V lesion mostly means rejection, usually means rejection. So isolated V lesion should not be used to diagnose T cell mediated rejection, except in DSA negative and some, except in DSA negative patients with some IOT. That means there has to be some amount of interstitial inflammation or tubulitis whenever you diagnose isolated V lesion and T cell mediated rejection. So this is my data in the last maybe 4 5 years. We have seen around 10 cases of isolated V lesions and 2 3 cases that behaved like antibody mediated process. And DSA was also done, which was positive, and C4D showed in 2 cases uh, a 3+ kind of staining. So C4D was 3, diffusely positive. But in like in this case, C43, in this case, C43, and in this case, the case which I have shown you right now, 7-day and 13-day, the 2 biopsies was done. This showed a minimal kind of C40 positivity. So isolated V lesion is currently a gray area in renal transplant pathology. And since its first description in 2009, there have been different speculation regarding its pathophysiology, whether it is a part of antibody-mediated rejection or cell-mediated rejection or a completely non-rejection process is still not clear. But as I have highlighted you, less than 1 year, if you find isolated V lesion, it could be no rejection. But 1 year post-transplant, if you find isolated V lesion, that could be manifestation of antibody-mediated process. So in the BAMF 2013 classification, the main impetus was the main impetus for this revision was the need to include C40 negative AMR. It was seen that there were some antibody-mediated rejections where C40 was negative. So if the C40 is negative, but there are histological criteria which suggest that it is possibly antibody-mediated rejection, then those patients should be treated on lines of antibody-mediated process. And they also suggested that molecular studies appear to justify the threshold value of glomerulitis plus peritubular capillary score or more than equal to 2 required for BAM 2013 classification for the diagnosis of C40 negative APR. So practically, what has happened since the last 9-10 years from 2013 till 2023, there is a lot of stress on microvascular inflammation. So if you find glomerulitis and peritubular capillary which is significant, even if C40 is negative, you should think in terms of an antibody-mediated process. So based on the revised 2013 classification, if you look at these criteria, microvascular inflammation quantitative criteria was laid down. So when I say quantitative criteria, microinflammation, G has to be more than 0. PTCs has to be more than 0. That means there has to be some amount of PTC capitals of lung. The other thing is, if you look here, any kind of V lesion. So any V lesion is suggestive of antibody-mediated process. So as compared to the previous classification system where it was said that 2000 till 2013, it was believed that it has to be V3 lesion to be labeled as antibody-mediated rejection. But now it was believed that any kind of vascular lesion, any kind of vascular rejection, more than any V1, V2, or V3, it could be a part of antibody-mediated process. Then acute thrombotic microangiopathy in the absence of any other cause, or acute tubular injury in the absence of any apparent cause. So practically there were histological criteria. So there is a all three features, acute or active antibody-mediated rejection, all three features must be present for diagnosis. The first is the histological criteria, which shows presence of ATN, microvascular inflammation, intimal or transmural arthritis, or acute thrombotic microangiopathy. And if and you have to demonstrate that there is evidence of antibody interacting with the vascular endothelium. So when the antibodies interact with the vascular endothelium, there will be linear C4D staining in the peritubular capillaries, or you will see a microvascular inflammation. So again, the microvascular inflammation becomes a part of the second criteria, second evidence also, along with C4D positivity. And the third evidence has to be serological evidence where you demonstrate donor-specific antibodies. Okay, so I'll not discuss about this chronic antibody-mediated process. There, I've already told you that chronic antibody-mediated process, all these three findings has to be there. The other thing was in 2013, they highlighted that electron microscopy should be done wherever available to diagnose early chronic antibody-mediated rejections. And it was suggested that duplication of the glomerular capillary loop on light microscopy, sometimes in early chronic AMR, can't be seen. So if you do electron microscopy, you will be able to demonstrate evidence of chronic AMR. So I will not repeat the same thing. Diagnosis of AMR, there has to be histological evidence. Three criteria: histological evidence, evidence of antibody interaction with the donor endothelium, and serological evidence. And the definition of these criteria have changed over the past 2 decades. So I'll just rush through this case. I will not discuss because this was an interesting case. This was a case where 2 biopsies were done, and this was a transplant. I think March 2014, the transplant was done, ATG induction, and at 1 month, the serum creatinine investigation showed 1.3 creatinine, but 6 months post-transplant, there was rise in serum creatinine and UPCR was 0.8. And this biopsy shows predominantly interstitial edema. You see this pale areas, this is interstitial edema. There is a lot of infiltrate, and this infiltrate was rich in plasma cells. So if you see rich, all these are plasma cells with the eccentrically pushed nucleus and the cytoplasm. So all these are sheets of plasma cells. So it is consistent with the plasma cell rich rejection. The glomerular capillary wall was fine. The glomerulus looked fine, except for there is some dilatation of the glomerular capillary loop. But the interesting part was there was some IgG staining, granular staining in the glomerular capillary loops. So I discussed with my nephrologist. I told him that there is a plasma cell rich ejection, but I feel there is some membranous component also. So since there was no proteinuria, so the membranous was like not considered as such, and this patient was treated on lines of a acute cellular rejection. DSA was negative. Patient received 5 doses of methylprednisolone, bortezomib, serum creatinine. There was further rise. There was no improvement. And as we know, plasma cell rich rejections are bad rejections, and they don't respond to steroids. They are steroid resistant form of rejections. So serum creatinine was 5.2 and UPCR was 2.19. A repeat biopsy was done at 7 months. And repeat biopsy again shows the similar kind of infiltrate which is there. And there was inflammation. There was no significant reduction, and the plasma cells were still persisting. But the intensity of IgG staining in the glomerular capillary loops, it increased significantly. Okay, so we labeled at POD 7 months also. It is a ACR PAMF1A, and there was MGN recurrent or de novo. There was graft loss in November 2014, and second transplant was done. So 5 months after first graft loss, and baseline creatinine was 1.3, and POD 13 there was rise in serum creatinine to 1.8. Repeat biopsy was biopsy of the second graft was done, second allograft was done, and it shows some amount of interstitial infiltrate, and there were presence of scattered eosinophils also which were there. The glomuli looked fine, but even in the second transplant, there was some IgG granular staining. You can see here. Okay. So it was labeled as borderline cellular rejection, early MGN, recurrent de novo in the second transplant. He was managed with 3 doses of methylpred, so POD 9 months. So everything was fine. And after 6 months and after some duration at POD 9 months, this patient presented with nephrotic range proteinuria. UPCR was 11.26, serum creatinine was 1.25. The membranous which we ignored in the first graft also and first transplant also. In the second transplant, it came 9 months after second transplantation. And now again, the IgG staining was persisting. We did IgG subclasses. So there was IgG1 and IgG4 staining. IgG4 was more strong. And we did PLA2R on both first and the second transplant. And we realized that PLA2R intensity of staining was very strong in the second transplant, but it was there in the first transplant also. So serum anti-PLA2R antibodies was positive. So the graft loss was not due to the first graft loss was not due to membranous. It was due to plasma cell rejection. But what I want to highlight is, as pathologists, we have to comment on any pathology, whatever we see, even if that could be incidental finding. I always write in my report that there is something unusual in this biopsy in form of some granular staining, which I can appreciate. So I always write, and you never know the significance of that incidental finding. Like in this case, that incidental finding was relevant, and it turned out to be a membranous, which the patient presented only in the second transplant, 9 months after second transplant, with nephrotic angiopoiesis. So in the recent, so last 2-3 slides. So in the recent 2022 BAF meetings, so there was something which they discussed about the IFTA part also. So there was uniform agreement that IFTA is a feature of poor prognosis, but IFTA doesn't represent chronic T cell mediated rejection. So evidence of IFTA as a feature of chronic T cell mediated rejection remains conflicting, because it was seen that there was limited response to anti-T cell therapies in IFTA. And the other thing was the molecular profile. When they did in these IFTA cases, they realized that some of these cases have evidence of antibody-mediated rejection also. So they said that yes, IFTA presence suggests it has poor prognosis, but presence of IFTA is not synonymous with the chronic T cell mediated rejections. And in the recent BAF meeting, also they discussed about the molecular tests. It is possible that they are going to become going to become companion tools for diagnosis soon. And the BAMF working group is seeking how to integrate the molecular diagnosis into the classification. So as we know that it is just about, they discussed a lot about microvascular inflammation. They feel the microvascular inflammation, it triggers the interaction with the HLA antibody. And what they have highlighted is antibody-mediated process is actually a continuum process. In the early acute antibody-mediated rejection, less than 1 month post-transplant, you are going to see all the classical features of ABMR in form of ATN, TMA, thrombi, mild capillaritis, V lesions, diffuse C4D positivity, and DSA being high. And in acute ABMR, usually clinically apparent, AKI will be there, ATN, thrombi, everything will be there, DSA will be there, C4D will be there. It is only in this active or smoldering ABMR, they have got a subclinical presentation. The capillaritis only is there. So they have highlighted that microvascular inflammation should not be ignored. So there is microvascular inflammation, that means glomerulitis and peritubular capillaritis, even if C4D is negative, even if DSA is negative or positive, you should always say that there is still a high possibility that it could be antibody-mediated process. And they say when it becomes a chronic active antibody-mediated rejection, you are going to see negative C4D staining, and DSA could be low and all that stuff. So what they want to highlight is there is activity and the chronicity index. The activity index will include the glomerulitis, peritubular capillaritis, the vascular thing, and the C4D positivity. And the chronicity index is opposite to that. So that means there will be CT. That means tubular atrophy. CI means there is interstitial fibrosis. CV means there is a chronic vascular ejection form of transparent arteriopathy, and CG means there is a transparent glomerulopathy in form of CG or chronic glomerulopathy. So the difference between 2019 and 2022 classification system is this thing. If microvascular inflammation, there is a new category which they have highlighted in 2022 BAF meeting. They say if evaluate the microvascular inflammation, the glomerulitis and PTC capillaritis should be equal to or more than 2 score. And if it is at or above the MVI microvascular inflammation threshold, evaluate the C40 in the PTCs and DSA. If the C40 is positive in the PTCs and the DSA is positive, it is ABMR according to BAF 2019 and 2022. But when you come to this area, where the microvascular inflammation is there, but C40 is negative, DSA is negative, according to BAF 2019, there was no ABMR. Okay. But in BAF 2022, they suggest that this should be labeled as microvascular inflammation, MVI, DSA negative and C40 negative AMR. So what I want to say is that the recent thing is BAM 2022, if microvascular inflammation is there, C40 is negative, DSA is negative. If you combine both these findings, there is glomerulitis, there is PTC capillaritis. If it is there, even if C40 and DSA is negative, you have to say it is a MVI, microvascular inflammation is there. These patients should be followed up because they say that these patients will land up with chronic antibody treatment. And these patients are like they say that it is the antibodies they are not able to pick up, but these antibodies are interacting with the endothelium, and the histological evidence of that interaction is there in form of microvascular inflammation, which is in form of glomerulitis and PTC capillaritis. So this is the last case. Just to highlight, the ABO incompatible transplant is different from conventional transplant. This is the ABO incompatible renal transplant, discoloration of graft on table, and 40 minutes after the graft was placed, a biopsy was done, and it shows thrombi within the glomerular capillary loops. Not all the glomeruli were affected, but there were few glomeruli which were affected. There were presence of thrombi. This is a high magnification to highlight the presence of thrombi, as well as there was evidence of neutrophilic glomerulitis. The second biopsy was done where the plasmapheresis was started, and the second biopsy was done at 12 hours post-transplant. It showed that TMA was persisting, and now the ATN is also becoming more severe. If you look at the C40 positivity in the first 40 minutes post-transplant biopsy, there was no significant C40 positivity, but in the second biopsy, 12 hours, you start seeing some PTC staining in the. So what I want to highlight is if you find C40 positivity in first 10 days or maybe 7 to 10 days in an ABO incompatible transplant, you should think more in terms of antibody mediated process rather than thinking that it is a competition, because the competition takes some time. It will not appear in the first 1 week post transplant. Okay. So obviously there has to be some histological evidence also in form of TMA, in form of microvascular inflammation. But the other point I want to highlight is when in an ABO incompatible transplant, whenever there is ABMR, the first morphological or the dominant morphological finding or histological finding is TMA, which is there. It's somehow these antibodies, they injure the endothelium quite extensively. That is why you find all these endothelial injury in form of thrombotic microangiopathy. So in this case, on 20 day, there was graft nephrectomy, and it was like the graft nephrectomy also shows. So obviously the third biopsy showed, which was done on 20th day, it showed cortical necrosis, and obviously then graft nephrectomy was done, which shows that majority of the vessels were showing these thrombi, which were including the lumen. And so this was the last slide. So this is all about the BAMF classification system. So if there are any queries, let me know. So I'll try to, so kindly check how to differentiate acute tubular injury from tubular cell enlargement due to viral cytotoxicity. So the thing is, acute tubular injury means that, so what happens is, whenever there is acute tubular injury, there will be some tubular epithelial cells. So if there is a ATN, there could be loss of nuclei also at places. and the tubules they try to regenerate. The problem arises when the tubules try to regenerate, and regenerating tubular epithelial cells are always larger in size, and they may appear like BKV tubular epithelial cells, because BKV tubular epithelial cells also there is a cytomegally. So similarly, a regenerating tubular epithelial cell will also show cytomegally, but the nucleochromatin structure is preserved. What happens in a BKV tubular nuclei is there will be nuclear inclusions which will be there. Okay, since my topic was not related to infection, it was dominantly related to the BAMF classification system. So BAMF scoring. So I didn't discuss about the BKV part, but this is how you can differentiate. And then obviously you have to redo SV40 in all biopsies, transplant biopsies. So even if you miss something on cytology, because sometimes BKV inclusions are not evident. So you have to do SV40 stain in all transplant biopsies to pick these lesions. Okay. So if there are any questions, I can always answer them. So what I want to highlight is important thing is that uh, uh, that you should not ignore microvascular inflammation. So if there is a microvascular inflammation, you need to follow up those patients, because those patients, even if this, because you have to understand C4D as well as DSA, it has got a waxing and a waning course. You will not find always DSA being positive, and you will not find C4D always being positive. We see a lot of cases of acute AMR also where C4D is negative. So, Puneet, if there are no further questions, should I?
Sir, there is one question, sir. I think.
Does MVI replaces term ABMR? I don't know. It is that will not happen, I assume, because the thing is, ABMR, the diagnostic criteria which are there, because not all biopsies the C4D is negative and DSA is negative. So there is good proportion of cases where C4D, DSA, and the histological evidence of AMR is there. Okay, it is only that there are some biopsies where you find microvascular inflammation. There is renal dysfunction which is persisting. And you have to understand one important thing in our setup. We don't routinely or sequentially do biopsies, or we don't sequentially do DSA also. Okay, it is only at the time of biopsy, maybe DSA is done. Majority of the times, you will say the patient is not affording and you will not get the DSA done. And on biopsy, if it is showing just a microvascular inflammation, pathologists also say there is no evidence of antibody-mediated rejection because there is no TMA, there is no evidence of any significant ATN, there is no C4D positivity. So he will say, no, everything looks fine. But the thing is, you can't ignore the microvascular inflammation. So if there is glomerulitis, if there is peritubular capillaritis, you need to follow up these biopsies, or you need to sequentially after few months. So they are going to lay down criteria also how frequently you should be doing DSA in these cases where the microvascular inflammation is there. Yes, the scoring is like it has to be the glomerulitis plus the PTC capillaritis score should be equal to or more than 2. That means the glomerulitis and PTC capillaritis both should be mild. And if any of them is moderate, then to surely it is quite suggestive of antibody-mediated process. So I don't think BAMF is going to replace ABMR by microvascular inflammation. What it has laid down is that in the near future, they are going to do molecular studies on these cases where C4D and DSA is negative and only microvascular inflammation is. And then they are going to come up with something possibly in the next BAMF meeting or maybe after next BAMF meeting. Surely something new is going to come. Yeah.
If there are no other questions, I think we can thank Dr. Rajan again. every time he does give an enriching lecture to all of. Thank you, sir. Thank you for
Thank
sparing.
you.
Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you. Thank you.
Thank you.